Mr. Chairman, and thanks for the invitation to share our results here with this exciting new piece of technology. So as the chairman said, there will be two presentations. And my presentation, I will start to explain a little bit about the physics behind this technology, and I'll show you some of the initial results that we obtained. And the next speaker will show more clinical results. Okay, so the principles of dual energy and spectral CT were actually first described by Hounsfield in 1973. But this group of authors, Alvarez and Makovsky, first published an extensive paper on this technology in 1976. So the idea is actually quite old already, but it was never really implemented due to all kinds of technical hurdles resulting in low spatial resolution, low SNR, and high dose. And so what do? So let's review the basics of CT for just a few minutes here before we continue on to explain what's so special about this system. So what happens when X-rays pass through the body? Well, there's a photoelectric effect that happens. There's a Compton effect that happens. There's some scatter and pair generation, but that is not relevant in the CT energy range, so we'll disregard those. And there are X-rays that don't interact with the patient, and they go on towards the detector. So these are the X-ray photons that hit the detector. And attenuation is basically a measure of how many X-rays reach the detector in relation to the photons that were emitted in the tube. Okay, so everybody knows that, I guess. So let's look at the energy spectrum on the x-axis here versus the atomic number on the y-axis. So basically what we see here is that in the CT energy range, two effects play an important role, the Compton effect and the photoelectric effect. So the photoelectric effect is primarily a low energy effect. Compton effect is relatively independent of energy in the CT range. However, if we look at these two, we can see that they vary as a function of the used energy. And this is the basis of dual energy or spectral CT imaging. And we can use this information to say something about what is in the voxel instead of just the density of the voxel. Okay. So this is an illustration of the photoelectric effect. On the next slide here, I have an illustration of the Compton effect. For those of you interested, read this paper. Everything is explained in great detail there on what happens. But these two components differ as a function of the X-ray energy that we use. So in conventional CT, we have a detector. The X-rays come into the detector, or the X-ray photons come into the detector, and after a while a light pulse is emitted as a function of the number of rays that basically hits a detector element, and what we get is a density value, a Hounsfield unit value. So with this dual layer technology, this changes. So we have a top layer which catches the, let's say, soft X-rays, so the low energy photons, and the bottom layer catches the hard X-rays or the high-energy photons. There's very little crosstalk between these layers, and in principle, we can use this information, energy 1 and energy 2, if you will, to say something about what's going on in a certain voxel. The nice thing about the dual-layer detector, as opposed to other vendor solutions, is that this technology is always on. It's always available, so you don't need to think about whether you want to use it or not. You don't need to set any special parameters on your scanner. In every patient, you get this information. Okay, so once we have the output of the dual layer detector, we basically have what is called spectral base images. We can reconstruct, let's say, normal images, conventional CT images, but we also have these spectral base images. And from these spectral base images, we can reconstruct all kinds of different new contrasts with our CT data, which we call spectral derived images. So one of the things we can do is we can look at monoenergetic levels. We can look at virtual non-contrast, so we can remove contrast from our structures, which potentially can obviate a non-contrast enhanced scan. And we can do material decomposition imaging. So more about that later. And we can also look at the effective Z, or atomic number, of a voxel. So all of these things are very interesting and have their own clinical value, as I'll show later. Now, if you want to do this correctly, basically what you want is perfectly aligned projectional data from the low and the high energies. And this is the unique feature of the dual-layer detector. We get this in a perfectly aligned projection. And no other vendor has this capability of generating these perfectly matched high and low energy projections. And in this paper here by Maas, was clearly demonstrated that completely matched projection data only is the best solution to get all of these new different contrasts. Okay, so a little bit about material decomposition imaging before we move on to the clinical examples. So, as you know, dual energy CT or spectral CT relies on the acquisition of two X-ray spectra instead of one. We have two detectors, or two layers in the detector, so we have two different spectra. And these spectra are separated to a certain extent, and this is demonstrated here. So the high energy spectrum is the blue spectrum, the low energy spectrum is the red spectrum from the upper detector. So, as explained earlier, different tissues have different combinations of photoelectric and Compton effects, and the attenuation in conventional CT at a certain X-ray energy is the sum of attenuation due to both the photoelectric effect and the Compton effect. But knowing the relative contributions, we can get information about tissue composition. So expressed mathematically, the attenuation at a certain energy is a function of photoelectric effect, P, and C, Compton effect. Illustrated graphically, we can do it like this. So we have different pairs of attenuation measurements at different energies, and this gives us the capability to study different materials. For instance, the photoelectric effect does not contribute substantially anymore above about 70 kilo-electron volt. So this does not play an important role anymore. However, the Compton effect is relatively independent, as I said earlier, and so this gives you a different combination of PE and Compton at 40 keV versus 120 keV. So this forms the basis of material decomposition imaging. So a little bit more mathematics. So we have the attenuation as a function of photoelectric and Compton, but we can also express this attenuation as a product of alpha and F. And alpha is a characteristic of the material and tissue, whereas F is independent of the tissue composition. So if we can get information about this alpha here with looking at the photoelectric and Compton contributions, we can characterize the material. So this is the key to material decomposition. Since we have low energy information as well as high energy information, we have two equations with two unknowns, and this is a system that can be solved quite easily. So, which is explained on this slide. So of course, we don't have perfectly separated spectra, and we don't have monoenergetic energies, but if we know the nature of the polychromatic beam that comes out of the X-ray generator, and we know the detector response, we can basically correct for this. All right, so let's look at how this works in terms of image noise. So dual energy CT, meaning rapid KV switching or using two tubes or using two rotations, gives you basically images or signal-to-noise characteristics like this. So here on the x-axis we have the monochromatic energy, on the y-axis we have the noise level, and we can see that with these solutions, basically at levels below about 60 kilo-electron volt or even 70, depending on the size of the phantom, the noise goes up tremendously. And this is a drawback of these methods. However, if you look at the dual-layer detector noise response over the range of kilo electron volt, this remains virtually flat. So we have the opportunity to reconstruct images with similar signal to noise over the entire range of kilo electron volt or X-ray energy. And this is quite useful, as we'll show later. Okay, so another thing you need to know that the noise is basically anti-correlated, which means that if the noise is high in the photoelectric images, it is low in the Compton images. And this can be used as a factor for model-based image reconstruction. So how does this translate into better images? That's something you are all interested in, I assume. So on the left side here, we have the conventional image. On the right side, we have the photoelectric attenuation part of the image. And this is rather noisy, but because we know the noise is anti-correlated, we can actually use this information in our model-based iterative reconstruction and then get images like this. So this is anti-correlated noise IMR reconstruction. And the noise is virtually removed, and this is then the basis for getting these virtually or low noise and high signal images over the entire range of the X-ray spectrum. This is also very important for material decomposition imaging. So what is material decomposition imaging in terms of gray values? Well, these two cylinders here have a similar attenuation, so a similar gray value at conventional CT, but they contain different materials. And if we plot on the horizontal axis the Compton scatter and on the y-axis the photoelectric effect for these two materials, there's a rather big overlap in these two clouds, if you will, of points that were measured. So if we use the anti-correlated noise information, however, these clouds clearly separate, and we are able to separate these materials quite well. So a question people often ask is, how does this work? The separation of the spectra is not as good in the dual-layer detector solution versus the other solutions that are out there. However, by using this anti-correlated noise, we can get good reconstructions, as we saw in the previous slide, but that's also demonstrated here in the situation where we have ideal separation. Photoelectric spectral images look like this. But in practice, of course, we have noise, so there's some overlap as well, and this overlap creates noise, so we get images like this. But if we use the anti-correlated noise properties, we can reconstruct and look at the different materials in great detail and high accuracy. Okay, so much about how this technology works. Of course, you're here to see images. So this is the first image I'm going to show. This is January 7, when the system was rolled into the Utrecht University Hospital and was installed. And pretty soon after that, we started using this system in our clinical routine setup. So we're scanning about 15 to 20 patients a day on this system. And we're close to 500 patients right now as we speak. So let's walk through some clinical examples and what the spectral information can do for you there. So a thing you often see for spectral information is the ability to differentiate the composition of kidney or urinary stones. And this is what I'm going to show in this slide. So on the left side here, we have on the top row, we have the transverse and coronal source images in the conventional Hounsfield unit reconstruction. So here we have a urinary tract stone. We can see it sitting in the left ureter here. And on the bottom here, I'm going to show you the effective atomic number overlay, which is shown in, let's see, this slide. There we go. So if we look at this, the color of this stone indicates that it's a high atomic number, so we know it's calcium and not urinary acid, and this has treatment implications for this patient. Okay, let's move on to the next slide. So here's another example of what this technology can do for you. So this was a patient with a renal mass at ultrasonography. So we scan this patient with a renal tumor evaluation protocol, and this is then typically what you get if you look at the conventional images. So we have this mass here in the right kidney. This is the arterial phase. This is the portal venous phase. This is the late phase. We measure Hounsfield unit numbers, and then we say something about contrast agent wash in and wash out as a function of time. So the first thing I want to show you is that using a low monoenergetic reconstruction, as shown on the right here, improves the delineation of this mass compared to looking at the conventional images. And again, notice the very good signal-to-noise properties, and the noise level here is about 19, and on the left it's about 21 in the conventional images. So at these low monoenergetic levels, we are still able to conserve very good signal-to-noise ratios. However, we can also look at the iodine content of this lesion instead of just looking at the Hounsfield units. So we have the iodine density here. It's a simple function of turning this on with a right mouse click in the portal or the PAC system. So we have 4.4 milligrams per milliliter iodine in this lesion right here. In the portal venous phase, this decreases with about a quarter, and then another quarter or so in the iodine density image in the late phase. And because we're using iodine, Telebrix is this contrast agent for bowel preparation, we can also look at the concentration there. Okay, here's another example. This is a patient with a cholangiocarcinoma, and I'm showing you the conventional image on the left and the monoenergetic 70 kilo electron volt, which is often seen as an approximate equivalent of the image in terms of the gray values that we typically see with a polychromatic X-ray spectrum. So we see this infiltrative process right here in the liver. And in fact, I think it becomes better delineated if we use this monoenergetic image. So continuing on, over the range of monoenergetic reconstructions that you can make, you can basically use a slider and pick the energy level that you like. We can see that at the low energy levels, where we are approaching the K-edge of iodine, the iodine signal becomes very bright. So these images are really nice for evaluating the vascular components or compartment of the liver. And if we go to higher energies, we can selectively look at more dense structures in terms of calcium and bone, etc. So if we look a little bit more closely to this lesion, we see that there's an area of low density in this lesion. And what is going on? Is this necrosis, or is this a cyst, or what's happening in this lesion? Well, let's look at some of the additional spectral reconstructions, and perhaps they can help elucidate what's going on. So the conventional image on the left, the iodine concentration image right here, which shows there's almost a zero iodine concentration. So this virtually proves it's probably a prior cyst or something that's sitting there. If we look at the effective atomic number, this is about 8, which corresponds to the effective atomic number of water. So this basically proves that this is a pre-existing cyst. A common scenario that we encounter is a renal cyst. And this was a patient not scanned for any renal pathology, but for something else. But then we see the cyst. So the next step you would typically do is perhaps look at ultrasound or redo the CT examination with a multi-phase exam, or even send the patient to magnetic resonance imaging. But now we have the spectral information, and we can look at the characteristics of this lesion by turning on a function called the magic glass. Let's see, there we go. So we can see that this lesion is of high density, and it has also an effective atomic number that's in the range of water, but it definitely doesn't contain any iodine, so it's not a solid mass, and it's probably a hemorrhagic cyst, this lesion. Let's see, here we go. Yeah, another obvious application of this technology is the evaluation of endoleaks. So this is a patient who just got an aortic bifurcation stent graft, and typically the images we get look like this. And if you are well versed in reading these images, You can see there's a little bit higher density right here, but the question is, with less experienced readers, it might help to visualize this endoleak in more detail. So that's what we've done with this low keV reconstruction. So this is at 48 kilo electron volt, and this beautifully delineates the extent of the endoleak quite nicely. So, of course, the blooming artifacts of the stent material go up at low kilo electron volts. So one of the things we can do is go to high kilo electron volt levels and look at the stent struts in more detail. So this probably also allows for better evaluation of that. Okay, the last example I'm going to show is this case. So basically, this was a pulmonary embolism CT scan, so we enhanced the pulmonary vasculature in this patient. Normally, we would go and look for filling defects in the pulmonary arteries, and that's, of course, what we still do. However, the spectral information now gives you the opportunity to not only see, okay, where's the iodine going, how much is there, so we can basically quantify the effect, the downstream effect of an obstructive clot. So we can look at the pulmonary parenchyma, the volume of the pulmonary parenchyma that's not being perfused anymore in this clinical scenario. So basically it allows you to look at the organ and organ damage, if you will. So I think this is going to be very interesting in routine clinical care. And with that, I'd like to thank you for your attention. This is the CT team at Utrecht University. So, I'd like to thank also our collaborators at Philips for all their help in getting us up to speed and using this exciting new technology. Thank you.
Thank you, Professor Lehner, for these nice presentations.